पल्लवी पल्लवी मैडम
स्टार्ट सर।
नहीं ये क्या पल्लवी, लेकिन आई थिंक वो वीडियो भी चला नहीं उसका, देयर इज सम इशू।
कॉल करें।
Diana, you can start now. Yeah.
A very good evening to everybody here, all the senior respected dignitaries, speakers, moderators, and all the important attendees. All of you who are making our session a very successful session. So, for our today's top academics, that is which are important tips for office practice in pediatrics. Today we are all gathered together for the same. So, welcoming all of you on behalf of Maha Academy of Pediatrics, Maha IAP, for this new series of academics. So, without taking much time in the initial introduction, let me first request our president, Dr. Ram Gopal sir, to say a few words, and then we'll move on with the first session.
Thanks, Diana. Welcome, everyone. This is the third episode of Tips in Office Pediatric Practice. As the name suggests, here we are giving, or our experts will give the small tips in day-to-day cases, what to go, how to approach the cases. That is more important. Now, for the same session today, we have two prominent faculties. The first topic is use of iron in children by Dr. Nitin Shah sir, and it will be moderated by Dr. Omkar Khandkar. And the second session would be on the movement disorder by Dr. Anup Verma sir, and it would be moderated by Dr. Sanjeev sir. Now, regarding Dr. Nitin Shah sir, I would just say one thing कि सर के बारे में कुछ कहना मतलब सूरज को रोशनी दिखाने जैसी वाली बात हो गई है. Today morning I was just reading his CV, and after the reading the CV I realized we are not even fetus also. Sir, and then Omkar called me saying कि sir मुझे इतना पढ़ना है क्या? Then I just told him कि you just name, sir का नाम ही काफी है.
अरे बाप रे, अरे बाप.
So welcome sir. One more thing about sir, not only the academics, whenever I have some administrative issues, I always call him, and he is always eager to help, and he is happy to help. So thanks sir. Our second expert is Dr. Anup Verma. He is a past president of AOPN. He is our past president of vice president of a CIAP, and he was EB from Raipur in the past. So welcome sir. I will not take much time because the topics are interested and everyone is eager to listen. So over to Diana. Already more than around 200 people have joined.
Yes, sir.
Yeah.
Thank you, sir. We all agree with what sir said about Nitin Shah sir. Welcome, sir. To start off, I want to welcome Dr. Omkar Khandkar. Dr. Omkar is a pediatric hemato-oncologist and immunologist. He's practicing at Kokila. He's attached to Kokilaben Dhirubhai Ambani Hospital, Navi Mumbai. He's always there at Nair Hospital, Kaushalya Medical Foundation in Thane. And he's always available on phone. Look at his CV. He has so humbly put up that his achievements are none. We know what your achievements are, Dr. Omkar. You don't have to put it down. So, Dr. Omkar, over to you to continue the session, to welcome sir and to start off with the session.
Unmute, Dr. Omkar. Dr. Omkar, unmute yourself. Pallavi ma'am, unmute Dr. Omkar.
Yes, sir. Done. Sir, kindly
Doctor,
try to unmute.
Dr. Omkar, unmute.
Omkar sir, you are co-host now. You can try now. Please
Yeah,
try.
now I can.
Yeah.
No,
Yes.
I
Thank
was
you. Thank
trying
you,
it.
sir.
It wasn't getting unmuted. So thank you, Dr. Ramgopal sir. Thank you, Diana, for giving that introduction. Yes, there are no achievements. You should go through the CV which sir has put up. I think it's a privilege, sir, I don't know whether I'm moderating or I would say to listen to you, to listen to somebody so well accomplished. I could see that you have passed in 1985, so you have an experience in the field more than my age. So I was like stunned, like completely. So fantastic to moderate this session. And one more interesting thing is, as a hematologist, I am also a hematologist. So I have always listened to iron, which is in hematology. So it'll be fun to listen to iron beyond hematology. So I'll begin the session, sir. So we all as hematologists, often constantly bombard the pediatricians with prescribing iron correctly and in iron deficiency anemia. So I would definitely love to listen to you about how you develop this interest in iron beyond hematology. Okay, and I'd like to club the question with another question, which will be the first question. Before we begin the talk, do tell us about the recent recommendations for giving iron in infants and children as per like various societies, maybe American Society of Hematology or Indian Academy of Pediatrics, whichever you prefer.
Sure.
So over to you, sir.
Yeah. So my last slide, Dr. Omkar, of my talk is about the NIPI program, which is the National Iron Initiative Plus Initiative. So there it will sum up the doses that you give almost throughout your life. Actually, you take iron, and I'll tell you why. So I will answer that at the end. And why I develop the interest in iron as a subject in hematology is because if you, I mean, and we all started as general pediatricians because when we passed out, there were no super specialties. I remember when I was working with Dr. Lokeshwar as the academic affairs administrator in IIP. I'm way back in 1990s, the time when Dr. Poddar actually started these IIP specialty chapters in the IIP, and then a lot of programs started in the medical colleges and Vadia, along with Sir Gangaram Hospital, Rajiv Gandhi, and some other one or two more. We were the first to start the FNB in pediatric hematology oncology, me at Vadia and others at Vadia. So when you do general pediatrics and you see a sick child, empyema, meningitis, sepsis, bad osteomyelitis, some skin infection, something, you will always see they are iron deficient. So iron deficiency, though may not be the direct cause of all these woes, but they are certainly one of the reason why the child is into a mess. You rarely see a good class patient with a good iron having bad pneumonia or a bad empyema and things like that. That actually interested that why we should study iron. So let me share my slides. Share the screen, share the slide. Okay. You are seeing full screen now, right? You are able to see the full screen, Dr. Omkar and everyone?
Yes, sir.
Yes, okay. So this is why give iron. I think that's the topic that I'm going to discuss. And whatever I've learned is, of course, from my teachers like Dr. Lokeshwar, Dr. Zinat Karim Boy, and others at Wadia, but also working at Hinduja and now at Apollo Hospital. So in that sense, I have learned whatever in these three great institutes. So this is the starking reality of iron deficient states in our country. So right from the National Family Health Survey second, which was done way back in 1998, 1999, when you can see children below the age of 5 years, 75% of them were iron deficient or they were anemic, most of them iron deficiency. Subsequent, every 5 years, the NFHS data kept on having from 2 to 3 to 4. And you can see the even in 2015-16 NFHS 4, the children below 5 years of age, 60% of them were still iron deficient. And look at the pregnant ladies, 50%, 57%, 50%. Nothing changed in these ladies. Now, what is interesting is men between 15 to 49 years, 25% in the last two surveys were actually were anemic, and that means they were probably iron deficient. And if you look at the Maharashtra, it's almost the same, 63% in NFHS 3 and 4% in NFHS 4 for children below the age of 5 years and almost 50% for pregnant ladies between the age of 15 to 49 years. And if you look at the current NFHS, which is very recently published in 2020, two states which actually have the major brunt of anemia in children below the age of 5 years, that's your first column. And all the ones which are red actually have deteriorated compared to the last NFHS data, which means you can see most of the states actually have deteriorated as far as the anemia incidence is concerned. And you can see Gujarat, 79% of children below the age of 5 years. Maharashtra, not far behind, 68% of children below the age of 5 years are anemic. So I think this is something which we need to tackle, because mankind is surrounded by abundant iron. All you need as an adult is iron, which is there in one small nail, which you put on the wall to hang your frame, and yet you have iron deficiency, which is not improving in the nation. So biochemically, when the iron is deficient, it leads to decrease in the heme protein. That's why you have decreased hemoglobin. I mean, that is very well evident. And once you are anemic, you are breathless, you have puffiness, you have edema feet, you have decreased output, you don't feel okay, etc. Everyone knows. So I'm not going to discuss that, as Dr. Omkar said, because what I'm going to discuss is why beyond anemia you should think how iron can damage you. Because it also has iron containing enzymes, especially in the brain. And that is the reason why iron deficiency not only affects the hemoglobin but also affects the entire metabolism in the body. And it is doing so through nucleic acid biosynthesis disturbance, oxidative respiration and mitochondrial function disturbance, and in the detoxification of the metabolic byproducts. So no wonder that when you are iron deficient, you have so many organs and functions which are actually going to be jeopardized, and not just the hemoglobin leading to anemia, though anemia may be the presenting symptom. Today, we define iron deficiency into different 4 ways. So we say absolute iron deficiency, which is usually dietary. That is the commonest in children. Infancy being the one up to 3 years. Bottle feeding is a big problem in our country. You can have secondary iron deficiency because of blood loss or pure absorption. Now, there is an entity known as functional iron deficiency, where you have iron, but it's not enough for the hemostasis that is going to happen. So you need extra iron, and that's where you patient someone who is like premature, who is put on, who is rapidly growing, or a premature who is put on, say, EPO, erythropoietin, and children with end-stage renal disease who are on erythropoietin, they have need for more iron. So that's a functional iron deficiency. Then your iron sequestration, that's a large group of diseases which are usually inflammatory or malignant diseases. That also includes chronic kidney disease, where the iron is there available in the body, but it's trapped in hemosiderin. So not available for active hemoglobin synthesis in the bone marrow. So it's like you are poor when your bank balance is so rich, but you are not having access to your bank balance. So that's a huge chunk of iron sequestration. And the commonest here would be malignancy and all rheumatological condition. Lastly, though rare but very exciting and once in a while we see in tertiary care institute, are the defects in the molecular defect in the iron metabolism. So you may have apherenemia, a hypotransferenemia, some other mutation, etc., which I will of course not discuss, because that's not what the general pediatrician should be interested in as far as iron deficiency is concerned. What they should concentrate is in the first one, which is the absolute iron deficiency. Now, let's come to the non-hematological manifestations. So there are neurological manifestations, which may lead to strokes, which may lead to intellectual and cognitive dysfunction and socio-behavioral issues. Epithelial, though they are rare, so you can get glossitis, cheilosis, which is common, platycoilinachia, which is more in adolescent and young women, and you can have esophageal webs, because of which you have Plummerson-Wilson or Plummerson-Ketty-Peterson syndrome, where you have dysphagia in a young woman and who's also iron deficient, and that's because of esophageal web. You have exercise intolerance, which is not only because of the low hemoglobin, but also because myoglobin has iron. So you decrease myoglobin leads to fatigue, and these children are usually not able to take part in active sports. And last but not the least, we don't realize that iron is a very, very important element as far as the immune function is concerned. So let's tackle one by one some of them. So let's talk about iron deficiency, how it affects the brain. So iron deficiency has been implicated in sleep disturbances, acute strokes, central venous sinus thrombosis, delayed development, impaired cognitive function, breath holding spell, which we know, and so many other CNS symptoms. So let's talk about iron deficiency in sleep. So you have something known as sleep spindles on EEG during your stage 2 NREM, the non-rotatory eye movement stage 2, where you are in deep sleep, okay? And that is the time when you actually are gaining memory and regulation of motor activity. So that's the best part. So if you have disturbed NREM stage 2 muscle sleep spindles, then you have difficulty in neurological function. And infants with iron deficiency at 6 months were proven to have decreased this NREM stage 2 spindles, and they had slow wave sleep spindle index. So which means they were not able to get good memory and cognitive function, which normally happen during sleep in a non-anemic child. And that's why you will see many times the parents complain when their child is anemic, that they sleep during the daytime. So they are like not, they are lethargic and they are not very interested. And at rest, they are at night, they are very restless. So they keep on kicking, getting up every now and then, keep on crying, etc. And remember, you can give iron, which will improve the hemoglobin. It will not necessarily change this disturbance in the sleep pattern. So that is the real reason why you should not only not try to treat iron deficiency, but you should actually try to prevent iron deficiency. So if you have fragmented sleep pattern, you have cognitive function, behavioral problem, emotional manifestation, irritability, hyperactivity, short attention span, low tolerance, frustration, clinging to mother or parents every time, and breath holding, and so on and so forth. So coming to breath holding, this was a paper which was published in 2018. They looked at 180 children who had cyanotic breath holding spells, and they took 40 children who were normal, who didn't have breath holding spell. And they could found that 66% of the children who had breath holding spells actually had iron deficiency, anemia, or iron deficient state. Now remember, you need not have anemia before you develop iron deficiency, because as you know, the first to go is the storage, then your plasma iron, and then starts dropping the hemoglobin. Now, more children with iron deficiency or iron deficient states, when they were treated with oral iron, they responded well as far as breath holding spells are concerned at 3 and 6 months. So you should give iron to children who have breath holding spell, especially if they don't have other neurological disturbance because of birth asphyxia. And not only breath holding spells, but children who have iron deficiency also know to have restless leg sleep. So they keep on getting leg pain and keep on kicking every now and then. So this study actually showed that the amount of breath holding spell was directly and significantly proportional to the drop in hemoglobin, drop in ferritin, and drop in iron level. And that's why you see children who are iron deficient, they are irritable, they're crying, and they actually then cry and breath hold, and they become cyanotic. Now, behavioral problem. Now, this is a very important study because it's a long-term study of children who are between 1 to 2 years and followed up to 15 years of their age. So it's like longitudinal study of what happens when you have moderate to severe iron deficiency anemia as an infant. So this was a double-blind randomized control trial done in Costa Rica, where they studied 191 children between 1 to 2 years who had iron deficiency. They were enrolled and they were treated with iron. And they took match control children who were not iron deficient, so they were given placebo to make it a control study. And they, at the age of 1 or 2 years, so 3 months after they were started on oral or iron therapy or placebo in the control arm, they looked at the Bailey's, they administered the BSID and they looked at the Bailey score, and then they followed up the children at 5 years and at 11 to 15 years. So at 1 to 2 years after treatment of the iron, you can see here those children who are moderate to severe anemic on your left hand side of your first figure on your left, you can see they were having much lesser mental developmental index as compared to children who are not anemic. Same is true for psychometric scores. And then those who remained to be iron deficient at 3 months as compared to those who became iron sufficient at 3 months, again there was a difference in the mental development and the psychomotor development score. So this very clearly shows the children who are iron deficient, they have decreased mental and psychomotor social activity. Now, as I said, the group that did not become iron sufficient at 3 months, in spite of iron treatment, they continue to have lower mental and psychomotor score in spite of correction of anemia. So remember, the brain and the defect in the brain are not connected to the hemoglobin level. They are connected to how much is the iron in the body. Now, at 5 years, what happened? At 5 years, the children, almost 163 of them were original children, were followed up. There was no difference in the growth or hemoglobin pattern. So that means the iron had worked and the hemoglobin had remained normal at 5 years. And yet, you look at the children who were moderately severe anemic, they had lower scores compared to the others on several scores which were done at 5 years, including the Goodenough, Harris Draw, Men's Test, etc., which are there put here, Wechsler score, etc. So that means those who were iron deficient as child, in spite of correction of anemia, continued to have lower score at 5 years. And at 11 to 14 years, when they were adolescent, 167 of these original children were still under evaluation. And you can see here, most of them had decreased verbal or full scale IQ. And I think that is very important. They had decrease in reading and writing and arithmetic problems. They had cognitive behavior. They had cognitive dysfunction. They have scholastic poorness. So they had needed special classes, etc. And they had behavioral problem like anxiety, depression, peer-to-peer relation, etc. So imagine children who are 1 to 2 year old and had iron deficiency. You corrected that by good iron by 3 to 5 months after the iron treatment started. When followed up to 15 years, they had this problem continuing. So if you summarize, there are at least 16 such studies which have shown very similar results, which show that on long-term studies, the children continue to have lower scores and their IQ can be lower by 1.7 points for each gram decrease in hemoglobin as an infant. Now, mothers who are not ready to stop the bottle and they don't listen to us and the children continue to have iron deficiency and they are listless, I tell them that you are going to bring the IQ of your child down by 5 to 6 points because they are say 6 gram, 7 gram, 8 gram. So their IQ will be down 5 to 6 points permanently. So I say your child could have become doctor, but he will actually become some ordinary citizen or maybe a male nurse. So that hits them because every mother wants the child to do the best. And that's the time when they stop the bottle. I think each one of you should use this IQ as the reason why you ask them to change the pattern of feeding of the child. Coming to cerebral strokes, so this was a study done in Canada where they took 53 children from birth to 15 years who had cerebral strokes, acute stroke. Now, in 16 of them, there was an etiological cause. And you can see here, out of this 16 or out of this 37, sorry, only one child had iron deficiency because they had other causes of stroke. Look at the children who did not have any primary etiology for stroke, 16 of them, and 6 of them had iron deficiency. So very clearly show that if you have idiopathic acute cerebral stroke, more often than not, you are iron deficient. And that is because iron deficiency leads to high platelet count, decreased, disturbed what you call rheological pattern of the blood flow, and that is the reason why they can have an acute arterial stroke. So 56, another study, 56 cases of stroke, 15 had no risk factor, 12 to 18-month-old children, and those who did not have any etiology, many of them had low hemoglobin and low ferritin. So you can see here for the cases which are iron deficient and control, you can look at the median hemoglobin was much lower in cases, MC was much lower in cases, median MC was much lower in cases, and platelet count was higher in cases compared to control. So very clearly association between stroke and iron deficiency is proven by these two studies. What about the central venous sinus thrombosis? So we talked about the arterial stroke. What about the venous thrombosis? So they looked at 42 children, 3 weeks to 13 years, who had central venous sinus thrombosis in a multi-centric European study. Now, 17 of these 42 had a known prior cause. So you leave them aside. You look at the 25, which was so-called idiopathic central venous sinus thrombosis, and they had 21 out of these 42 had microcytosis. So again, that tells you that they probably had iron deficiency, if not iron deficiency anemia. So even strokes in the venous side are somewhat related to iron deficiency as a primary cause. And coming to the fetal outcome, if the mother is iron deficient, initially we used to thought that the baby is like an obligate sucker of iron and all nutrients. That is proven to be not true. If the mother is iron deficient, she will have babies who are low birth weight, low in height, low in head circumference. They may be preterm. They will have higher incidence of birth asphyxia. They'll be born with low iron store and ferritin, and that's why they will need iron supplements even faster than a similar child born with a mother who is otherwise normal. And these children can have adverse mental and psychomotor development that can persist like in a child who's anemic at 1 to 2 years of age. So maternal anemia, iron deficiency is even more devastating right from the fetal age till the child comes out. So you can see here, this is a study done in Delhi where they looked at mothers who had hemoglobin of 7 to 9, 9 to 11, more than 11. And very clearly you can see the birth weight of the children born to these mothers were definitely lower when they were moderately anemic compared to non-anemic. They had decreased length as compared to non-anemic, and even head circumference was lesser as compared to non-anemic. These were all statistically significant, and that is probably because the placenta was smaller in mothers who were iron deficient. So obviously it could not transmit the nutrients that are required for the proper growth of the child. Okay, and now if you treat this mother when they are pregnant, so 215 women who are anemic were given iron folic acid for 100 days, and another 203 women served as a control. And you can see that those who were treated with iron and folic acid tablet had a birth weight which was 2.8 plus or minus 0.4, compared to control group where the mothers were not given iron had a birth weight of 2.59 plus or minus 0.34. So almost 300 to 400 grams birth weight lesser. And you look at the lower birth weight incidence, 20% versus 40%. So if you treat the mother, you prevent many of these complications in the to be born baby in the next few weeks. Now coming to immunity, iron deficiency is known to decrease T cell function, both the number and the function. It also decreases neutrophil function because iron is a part of the enzyme MPO, the myeloperoxide. So iron deficiency has been associated with increased chances of skin and soft tissue infection, fungal infection, surgical infection, etc. At the same time, iron can lead to oxidative damage. So what do? Do you give iron or you don't give iron in a child who's infection? So let's look at this. So this is a study done on iron and effect on the acute lower respiratory infection like pneumonia. This is done in Egypt, and you can see here in anemic compared to non-anemic, there was 4.6 times more chance of acute LRI, and iron deficiency present or absent, again 4.7 times more chances of developing an acute LRI. Not only acute infection, look at the second graph, which is recurrent chest infection, 27 times more if patient was anemic and 10 times more if he had iron deficiency without anemia. So iron deficiency definitely leads to increased infection, not only acute respiratory, lower respiratory, recurrent chest infection. Even in adult population, they've looked at the septic arthritis, which is found to be at least 2.5 times higher in adults who are iron deficient compared to adults who are not iron deficient. And this is the meta-analysis which looked at 28 randomized controlled trial to see whether giving iron therapy to sick babies can increase the incidence of infection. So you can see the pooled incidence of infection was 1.02 with confidence intervals minus 0.9 to 1.08. So it was statistically not significant. And same you can see here, each of the infection, whether it's diarrhea, non-diarrhea, respiratory, malaria, etc., none of them was statistically significantly more when you give iron supplement. So the point is, if not while they're in hospital, at the time of discharge, definitely give them iron because iron has no impact on increasing infection, whereas iron therapy will definitely decrease the infections. As you know, children don't come back for follow-up once they are out of the hospital. What is the choice of iron therapy then? You have oral, which works wonder in children. Most of the children don't need any other IV iron therapy. There is some role I will discuss a little later. You can give daily iron, which is the best. And the current IAP recommendation of the anemia and the iron deficiency group has said that 3 mg per kg of elemental iron is more than enough. Give it at night, bedtime, so the child goes to sleep, has less side effect. If he doesn't tolerate, give it with the food, no issue. If still doesn't tolerate, give it two divided doses in a day and still not tolerated, then only you have to think of IV iron. Look at the efficacy, compliance before you jump to IV iron. And iron prophylaxis is something what Dr. Omkar mentioned. So we have this National Nutritional Anemia Prophylaxis Program, which is now this National Iron Plus Initiative. I'll show you that as the last slide. So when you give the iron therapy orally, take the correct salt that you are aware of. So take iron, ferrous sulfate, ferrous fumarate, ferrous, any ascorbate, anyone which you like, but know the content of the syrup that you're writing, 3 mg per kg of elemental iron per day, and that should be the therapeutic dose that you would give. You will give it for at least 2 months after the hemoglobin has become normal to replenish the iron stores. So generally, it takes 2 to 3 months for the hemoglobin to become normal. So we are talking about 4 to 6 months of therapy. Do the bottle count or pill count because the mothers are lazy, they forget to give iron, and look at the response by at least doing a CBC at 1 month and at 3 months. And by 3 months, if it is pure iron deficiency, the hemoglobin should become normal in any iron deficient patient. Diet, don't forget iron therapy. Iron deficient anemia is not just giving iron, it is giving breastfeeding to the mother, but giving too much breastfeed beyond 2 years is not correct. Stopping the bottle 100%. Treat the infection and infestation. Don't forget to deworm them. Treat the basic cause, whatever the cause may be, etc. Especially the diet. Like hemoglobin is not only heme, it's also globin, which is protein. So if you don't have a good balanced protein diet, you will not form hemoglobin in spite of tons of iron you give to the child. And prophylaxis, as I said, I speak at the last. So I come back to these 4 different things we said. Absolute iron deficiency, they can all be treated with oral iron. Absorption in celiac, once you put them on gluten-free diet, again they can be treated on oral iron. So the only malabsorption which are not correctable, like a short bubble loop, etc., may need IV iron. Otherwise, in the first group, it's all oral iron. In the second group of functional iron deficiency, yes, when the patient is put on EPO, you try oral iron, but it's not sufficient. You can give them supplemental IV iron. In the third group of sequestration, you have to give IV iron to overcome the blockade that's happening because of high hepcidin level. So you give them IV iron, thinking that some iron will go to the marrow. And of course, some of the molecular defect also will need IV iron therapy. And can you give twice a week, once a week iron? Yes. As a prophylaxis, it will work well. As a therapeutic, it may not work well because it will correct the hemoglobin. But you can see the iron stores don't go up when you give once a week. So at least twice a week is something which I would say is good enough as an iron therapy. Uh, so this is so that was iron therapy. You can see in iron therapy the stores don't go up, but in prophylaxis it doesn't matter whether you give daily, weekly. It works absolutely wonderful. So in your anemia prophylaxis program, you can give once a week, you can give twice a week, no issue. And just one slide on IV iron. You have several molecules. What we used to so far use was IV sucrose iron in children because the ferromaltose was not, carboxy maltose was not tested in children. But now we also have paper on the safety on carboxy maltose. So the difference is IV sucrose iron, you can't give more than 4 mg per kg per time. So if suppose a 20-kilo child needs say 400 milligram of iron, you can't give more than 80 at a time. So you will have to call him 5 times, once a week over 5 weeks. Whereas the carboxy maltose, you can give the total iron that you have calculated in one go in your OPD in just 2-3 hours in 100 cc of normal saline. Both these molecules are absolutely safe as far as anaphylaxis is concerned, and that's why you can even give it on an OPD basis. There's no need to admit this child and keep them for overnight or something like that. But as I said, there are very specific indications where you will use IV iron. Don't abuse it. At the same time, don't get worried if you have to use it for the correct indication that I discussed in the last 2 slides. All right, so I just end my story. This is a common scenario. You have a child who is he was got say this is like say 3 years old child, pallor since few months. He had pica, failure to thrive, so he was not growing well. He had diarrhea twice. Once he was admitted for pneumonia. He was born at 37 weeks, so little preterm. LSCS, so no one allowed the cord clamping to be delayed. He was born 2 kilos. He was small at the time of birth. He was breastfed only for 2 months, and then he was started on bottle feed with diluted cow's milk, and he was weaned with some gruel of rice and dal only at 10 months, so essentially on diluted cow's milk. The mother herself was only 19 years malnourished. She was iron deficient herself. This child is pale, edematous, puffiness, malnourished, fretful, listless, clings to mother. Hemoglobin is 7 gram, MCV is 55, RDW is very high. On a smear, you see hypo, micro, and ISO. If you had a complete hemogram, you would see also the platelets are 6.5 lakhs, 5.5 lakhs, like that. So what went wrong with this child? Why he is in such a condition? And you see, these children are plenty in our community, especially in the rural community. So young mother, she herself had poor iron. No one gave her iron during pregnancy. Born preterm, so less placental transport. On a LSCS, no one did delayed cord clamping and give that extra transfusion to the baby. Not breastfed. Cow's milk is very poor in iron and very poor absorption. Late weaning, so not giving good iron and not giving good protein. Recurrent infection would prevent even that little iron to be absorbed, especially when there is diarrhea. No supplements of iron were given when tons of vitamin B complex were written for this child by various physicians and pediatricians, and he was picked up at 2 to 3 years. So late diagnosis. So as I told you before, now you treat this child with iron, his hemoglobin will become normal, but not necessarily his cognitive function will become normal. So you treat with iron, his hemoglobin is normal after 4 months. Can you tell the mother this child will do exactly very good as scholastically and will do exceedingly well in the school? I don't think so. I can give that answer as yes. It is God's gift if it happens, but more often than not, this child will not do well in the school, even as I showed you till 15 years of age. So that's why this last slide is the National Iron Plus Initiative. Of course, the doses have recently changed, but doesn't matter. Remember, this program says to start iron at 6 months. I prefer to start it at 4 to 5 months when child doubles the birth weight. That in a preterm child may be as early as 6 weeks. So remember, you start iron when the child doubles the birth weight. First 5 years, you give 20 milligram of elemental iron. 5 to 10 years, you give 45 milligram elemental iron, 10 to 19 years, 100 milligram. And you also associate with the folic acid. Pregnant lady and lactating women, you can give it as a therapeutic dose twice a day if they are anemic, or as once a dose for prophylaxis. And women in reproductive age continue to take iron 100 milligrams. So you can see you are almost taking iron your lifelong. So it's bi-weekly in the first 5 years, weekly thereafter. And during pregnancy, I said it's daily. So let's give iron to our children, because then we are doing well for them, not only for physical well-being and good hemoglobin, but more mental well-being. And let's treat our mothers with iron so that they give birth to normal children with good weight, good height, good brain, and good iron store, so that they don't become iron deficient and have the problem like this previous child had of having very severe anemia and maybe a scholastic backwardness as the child grows. Well, to conclude, anemia prevalence is very high and unacceptable to me. And if you can sell pan and gutka at every nook and corner of the country, why not iron? So just put iron in some gutka. I mean, I'm just joking, but that's the way. So you have iron salt fortification, which has been tried, etc. Hepcidin ferroprotein pathway controls iron metabolism. So if you have high hepcidin like an inflammatory disorder, you will have iron deficiency like picture. Iron deficiency has effect on cognition, strokes, immunity, fetal well-being. Recent IV preparation are extremely safe, but should be used only when they are actually indicated. Most of the time, iron deficient patients in our day-to-day practice are the ones which can be treated with oral iron. And if the child can not tolerate, give this less dose, divide in two, etc. Even make it alternate day, but see that you give iron to the children. And don't forget to put every child which you see on iron prophylaxis right from 6 months till the child is 18 years and moves out from you to the adult physician. I would like to thank the MAHA-AP for inviting me here, especially Dr. Ram Chejera, Dr. Sanjeev Joshi, and all others. And over to you, Dr. Omkar, for question answer.
Okay, thanks a lot, sir, for that wonderful session. I think it was an eye opener because we honestly have never looked into iron and its role in so many CNS events. So that was definitely an eye opener, and I don't know, the sleep disturbances and everything, we are linking that to iron. So my question actually is to if you can throw some light on importance of iron supplementation. They always say in the first 1,000 days of life,
Correct.
which matter the most. So,
Correct.
so why is that distinction always been done in the first 1,000 days? One more question, sub question to that is: are these first 1,000 days starting at the conception, or they are starting at birth?
Correct. So you cannot give iron to baby who is in the mother's womb. So mother will take the iron. So that's the first three, the 9 months or whatever through 70 days that the baby will be inside. But after birth, the ECD program and the other, not only for iron, but so many other neurobehavioral follow-up of the babies, first 1,000 babies, because first 3 years, 1,000 days is like 3 years, right? So first 3 years are the most important for the brain growth. Then you still continue to grow till 5 years, but you start using the brain more often. And then after 5 years, you just use the brain. So when the brain is growing, if there is lack of iron, lack of other nutrients which brain requires, then you will have permanent cognitive dysfunction, which may be subtle, but is damaging to the baby. And that's the reason why we say at least give for first 1,000 days, but ideally to at least for the first 5 years, and maybe give till adolescence.
Okay, so yeah, that's an important point, sir. Because again, I'd like to put one fact here that the newborn generally consumes 60% of the total calories for brain development, whereas we all consume only 20%. So that's a distinction. So the nutrition does matter. So that brings me to the next question, sir. They always talk about free radical injury because of iron in the
Correct.
first 3 months of life. So how do you balance that? And
No, so you don't start iron in the first 3 months of life. You
correct,
start it at
correct.
5 to 6 months. That's the reason. But in a preterm baby, it will not apply, because moment you're iron deficient, the damage is more by not giving iron than giving iron. That's the reason why you start when double the birth weight. I think that is the mantra for the practicing pediatrician. Suppose a 1.2 kilo child birth baby born become 2.4 at 4 weeks. Start iron that time. Many neonates start iron at the time of discharge for the same reason.
True. True. Yeah, so that's important. We generally start the iron in the preterms also as the birth weight doubles, but not
Yes.
immediately at the time of
Sure.
post delivery. So that's
Correct.
important. Again, sir, one more question here is you talked about that study. I would request you to share that study on the group about
Please.
iron not
Omkar,
being directly
Omkar,
related to. Yeah,
Omkar, I just want to interrupt you.
yeah, sir. Please go ahead.
Usually on this session, we take question answer after we finish both the talks. So if at all,
Okay. Oh,
uh,
so sure.
yeah, because
My bad.
Nitin
Definitely.
sir
We'll
will
go
be
ahead with the next
bombarded.
topic.
Nitin sir will be bombarded with so many questions. I know. That will take another half an hour.
No problem,
So,
sir. We can go to
No
Dr.
problem,
Anup
sir.
Verma. Sure.
Definitely.
Thank you, sir. Thank you.
yeah. So sir, you have to hang on, huh? Nitin sir,
I
हम
am
आपको
here.
छोड़ेंगे
Don't
नहीं
worry.
है. हम आपको छोड़ेंगे नहीं.
मी आता नेपथ्याला चाललोय पण मी आहे इकडे मी ऐकतोय अनुप वर्मा आले आणि त्यांचं ऐकलं नाही तर कसं चालणार.
Thank you, sir. Thank you, Dr. Nitin Shah, sir, very elaborately. Why to give, what to give, when to give, and how to give was very crisply conveyed to all we pediatricians. Thank you, Dr. Omkar, for moderating the session as well. We will take the questions at the end of the second session. So moving on for the next session, which is movement disorders in children, which is a very important topic as well and routinely might be we come across quite often. To moderate the session, I invite Dr. Sanjeev Joshi, sir. Sir is the EB member from Yavatmal and he is the president of AOPN chapter. Sir, I would request you to introduce the speaker and then move on with the session.
So a very good evening all. Respected President of Maharashtra IP, Dr. Ram Gopal, Secretary Amol, and our two distinguished speakers, Dr. Nitin Shah sir and Dr. Anup Verma sir. On behalf of Maharashtra IP, I express my sincere gratitude for accepting our invite. We had a wonderful session with the Doyen himself, Dr. Nitin Shah, and now we are coming to another Doyen of pediatric neurology in this country. As we know, movement disorders, one of the common neurological problems in children, and it includes a range of neurological symptoms. And the main issue is abnormal tone, abnormal posture, and plus minus involuntary movements. It could be sometimes a benign condition, but sometimes it could be one of the presentation of a major neurological syndrome as such. So, how to approach movement disorders in a day-to-day practice? It is well said that picture worth hundreds of sentences and a video worth thousands of pictures. So, friends, movement disorder, which is a diagnostic dilemma, can be best solved by a video presentation. And we have the master of video presentation in neurology, none other than Dr. Anup Verma, past National Vice President, past EB, past President of AOP Neurology and Secretary, National Coordinator of AOP, has contributed to a lot of books. He is editor to so many books of IIP publication also. So, and the most important thing is, it is all his collection. And not only collection, he has got a follow-up of almost 10 years for those videos. So I will not interrupt between the august audience on this virtual platform. I will request Anup sir to start his lecture.
Dr. Joshi, with your kind permission, I would just like to add that Dr. Anup Verma is the doyen of neurology and a don of molecular movement disorder. For general pediatrician who are not getting his weekly clinical quiz, not only neurology, pediatric, you should ask him to send to you because they are really good learning process, especially for students and the new beginners in the pediatric practice. Over to you, Anup.
Sir, is it my slides are visible, sir?
Yeah.
Yes, sir.
Yes, sir.
Just update. Just a minute.
Anup, you can see that arrow play on the top.
Yes, sir.
There. No, on the left side.
Left side.
Yeah, that's right.
Yeah.
Correct.
Yes.
Just
Yes. Got it.
Try to move the slides, whether you're able to move. Yeah.
But I have just, yeah. Sir, thank you so much for the opportunity given to me. And I am very, very thankful to Maharashtra IAP, especially our President, Dr. Ram Gopalji, and the dynamic secretary, Dr. Amol. And I am really privileged to share this stage with Dr. Nitin Shah, which is a really admiring personality, and he is known to me since more than 3 decades, and I am fortunate to see him as a treasurer in the executive board of 1999 and 2000, and also seen his working as a secretary. Unmatched quality. He is best in everything. Maybe a treasurer, maybe a secretary management, and as a president, we all know. We are really very, very fortunate that he is amongst us in this platform, sharing the knowledge. And thank you, Dr. Sanjeev Joshi, who is chairperson of the national chairperson of AOPN and the executive board representing the Maharashtra. And other dignitaries on stage. And I am very fortunate to share this presentation. And we all know that to acquire knowledge, one must study, but to acquire wisdom, one must observe. See, this observation is very, very important in any walk of pediatric medicine or medicine in general. So what is observation, we will see, and how to conclude these observation is again a very important aspect. Now you are seeing that movement disorders are always better observed than described. This is a really very important sentence, that you have to observe critically and then come to conclusion. And as Dr. Sanjeev has already said, the William Osler, what has been said, the picture is worth 1,000 words and video is worth 1,000 picture. I cannot define an elephant unless I have seen once. So is true for each type of movement disorder which we can which we can see in our OPD practice. So the aim of my talk is to improve the power of observation. We will just see the case and we will observe critically and we will reach the diagnosis. We will bridge the basics. Just pattern recognition in all abnormal movement is very important, and various case scenarios which can be which are available in our OPD routinely. These are the two patients. One is exhibiting hyperkinetic movement and one is exhibiting hypokinetic. These are the two main types of abnormal movement which we can categorize. On the right side, you are seeing that this is a patient who is exhibiting lowness of movement. Small movements are there. Even he is walking with see, you can see stooping. He is not moving the arms as well. The finger tapping is poor. So this is a hypo, which is very rarely seen. More we are concentrate on the hyperkinetic movement disorder. We will touch upon the various phenomenology. We will not discuss the treatment part because it is again a very lengthy subject. So video and photographs is the power of observation. It is this is very, very important. It is not the power of, you are seeing that this is the spectrum of movement disorder. You name a movement disorder and it is here. Maybe a myoclonus, dystonias. Just observe the different videos and you will be able to differentiate what type of abnormal movements the patient are exhibiting. Here is a lady, here's a small girl exhibiting abnormal movement, and the question comes whether she is exhibiting a seizure activity or she is exhibiting a movement disorder. So what has been said that movement disorders disappears during sleep and seizure may persist or sometime it may worsen. Secondly, movement disorders have a more stereotypic appearance and more persistent than seizure, as this child of Rett syndrome is exhibiting the stereotypic movement. Seizures are accompanied by loss of consciousness or awareness. Movement disorders are not. Whereas every seizure activity can have a representation in EEG, whereas we don't find a chorea having the EEG abnormality or dystonia is having the EEG abnormality. These are the four important points which we can differentiate that this patient is exhibiting movement disorder or seizure disorder. Senseful observation is a pattern recognition. That is very, very important. We all see cases, but seeing the cases sensefully is observation. That is very, Amdekar has always said that watch the patients with your observation, senseful observation. And you are seeing that there is a no more difficult art to acquire than the art of pattern recognition. So you have to see or analyze every case systematically. Well done is half begun. So you have to assess each patient, just concentrate on the head, concentrate on the trunk and the upper limb. Most of the information by the patient who is exhibiting abnormal movement is giving from these three areas. This is very, very, and this is a way how we can go ahead with the pattern recognition. Now, the phenomenology, this is a sequence of event, what this the phenomenology. Here is a patient, watch the video. His jerks are very sudden, non-repetitive. These are non-pattern movement. They are more proximal than distal. They are random. You are seeing in the random in time. Each movement has a distinct start and the end points. You are also seeing that they have the constant motion, they're fidgeting. Trunk, face, and extremity. Just observe the trunk, face, and extremities. These are the three videos. You can see that overlap is the rule rather than exception in movement disorder. This is the same, almost same movement disorder. They only differ in the amplitude. In the middle, patient is having a phenomenology of the chorea. On the left side, the patient is having a athetosis, which is seen in a small writhing movement, more marked distally as this patient. Whereas balismus is the severe form of chorea. Ballistic, sort of violent, flinging sort of movement the child is exhibiting is the balismus, though they are in the same category of the chorea, milder to very severe form. Another patient, you are seeing this patient who survived the neonatal period having a severe jaundice to the tune of 32 milligram. Post-kernicterus was there due to G6PD deficiency. And you can see the chorioathetoid sort of see the abnormal movement the child is presenting, and see the MRI, which is representing the hyperintensities in the globus pallidus and the substantia nigra. The most important was, you can just see, he was advised to see upwards. He cannot. So this is the upward gaze palsy is a feature of patient having chorioathetosis due to post-kernicterus. Another phenomenology of tics is the child just observe this video. Tics, rapid, non-voluntary, repeated segmental movements. And simple tics, we all know that it lasts less than 6 months, and the chronic is more than 6 months. You can see these are the phonic tics. These are the phonic tics. Complex motor involving the multiple muscle groups, and simple motor tics are brief, stereotypic movements are there. Dystonias are really very painful, very painful. Abnormal posture, twisting in nature, extreme extension or flexion. These are the extreme form, really a painful. You can also see that having the abnormal posture, and the lower video is a stratal sign. You are seeing the abnormal foot inversion was there. You can see this is the examples of dystonia. It can be triggered by the abnormal movements. Now, here is another movement disorder known as the myoclonus. There is a sudden shock-like jerk the patients are exhibiting. This is a classical of myoclonus. You are also seeing the lack of identifiable posture. Sudden jerks are there. It cannot be suppressed as we used to suppress the tics. Here is another phenomenology of tremors. You are seeing this video that this is a rhythmic alternate contraction and relaxation of agonist and the antagonist muscle. This is the rhythmic oscillation at a certain point. This is what the video is showing, is that symmetrical velocity, and it can be associated with other movement disorder like dystonia and dystonic tremors as well. Now you are seeing the stereotype. Stereotypes are the repeated pattern movement as against the chorea, which is the non-pattern movement. You are seeing the voluntary, it can be suppressed, simple back and forth. This is the flapping, hand wringing, hand washing movements of the classical Rett. These are the patients which are less than 3 years of age, and lower limbs are not typically involved. That is, the stereotypies are most commonly seen on the upper limb. They are bilateral. There is no premonitory urge as we see in the ticks. Here is another video of a girl who is exhibiting abnormal movement, and what you are seeing is this is the hemi. The phenomenology fits with the chorea, and typically this chorea starts from the appearance of the strep infection, as the upper photographs is depicting. That is the very classical donut sign. That is the signature of strep infection. And if you see that, you have to treat with the narrow spectrum penicillin for adequate length of time, so that we can minimize the consequences of strep throat. And you will see that 20% of these chorea patient can have a unilateral involvement, as in this patient. This is the hemichorea. You are also seeing the tongue fasciculation and other signs of chorea. So fasciculations are visible. You can see that. Though these are rare, but just to make you aware that you have to don't miss this sign also. Though there are other causes of fasciculation of the tongue, and these are the classical signs of chorea. This is the spooning sign. You can able to elicit the pronator sign, darting tongue, and milk-maid grip are the classical sign of chorea. But it is not the etiology specific. A chorea of the lupus can also exhibit this. Drug-induced chorea can also exhibit all the set sign of chorea. So you have to elicit other signs of chorea as well. Now coming to the gait, you are seeing, just concentrate how this child of chorea is walking, lurching gait, unstable, dance-like, affecting the trajectory of the lower limb. Both the patients, you can just observe these videos. Another patient exhibiting chorea for a moment. See the abnormal head movement. He is not able, he is having a poor vision. She cannot look laterally. She has to move whole of the head laterally. This is what is the oculomotor apraxia is. See the classical MRI of the molar tooth sign of the Vermean agenesis. You can see the drusen deposits, and this is a very classical of Zubert syndrome, the very classical presentation. Another patient exhibiting head tremor, tongue tremor. He had recently lost his milestone after 15 months of age. Thin pigmentary hairs. Now, there is a immediately answer come in our brain that this is definitely a case of ITS, and this is the investigation which we are seeing. Thin pigmentary anemia, as Dr. Nitin sir has enumerated very nicely regarding the every aspect of the anemia, regression, hypotonia, tremors are another classical. And in spite of the lot of literature for more than 6 decades, this condition is known, but yet no confirmatory or conclusive etiology has been known. And we know that it has a long, even they survive, and they usually survive long-term cognitive and language neurodeficits. This is the follow-up up to 5 years. You can see the follow-up of this patient. Another patient, just see the hairs, which is very important, pigmented hairs and eyebrows are there. Another patient, this is also known as NIB syndrome, neurocutaneous infantile B12 deficiency syndrome. This is the new name of ITS because vitamin B12 deficiency has been found in these patients quite frequently, and this is the new name given to ITS. What is this sound known as? Close your eyes and listen. This is a classical bleating of a lamb cry. This is a classical of ITS. You can see the skin pigmentation. You can see the skin pigmentation in the last patient, and you can also see that this patient was having a vacant stare, open mouth, Parkinson-like appearance, and tremors are there. This is a classical of ITS. Another patient who is 1.5 years of age, extreme irritability, extreme. That is very, or make you aware that any patient who is exhibiting extreme, just watch his eye movement. That is again very important, and you will see that you can pick up a rare condition, said to be a rare condition, but if your eyes are tuned, if your brain is tuned to pick up abnormal eye movement, you can reach to diagnosis then and there. Shock like jerk, mini myoclonus are there. That is very important. Now see the opsoclonus in this patient. So this is a classical of OBAS, and neuroblastoma was picked up in this patient, operated upon, and you can see the we can know that this OMAS, opsoclonus myoclonus ataxia syndrome, can be due to neuroblastoma, can be due to ovarian tumor. Flu vaccine can also sometimes parasitic OMAS. There are so many infections, as it is depicted in this book, can have a etiology of OMAS. Another patient you are seeing, very restless. You can see the eye in this patient. Another patient of OMAS, you can see the CT was absolutely normal in this particular patient and was a non-tumor group. And you can see the patient, this after this. This is the third patient of OMAS. See the eye opsoclonus in this patient. Absolute irritability was there. Chaotic eyeball movement. This is again a non-tumor group of ATS. So opsoclonus ataxia myoclonus syndrome can be picked up just by observing the abnormal eye movement, which is the basic clinical sign, and then you later confirm by the neuroimaging and other method of the diagnosis. There are two videos. Number one is exhibiting abnormal movement. He is absolutely normal while he awake, but when he sleeps, these are the abnormal movements. Number B, again having these abnormal movement, but so many time he is used to exhibit whether he is sleeping or he is awake. So the phenomenology of the number A patient is everybody can say that this is a sleep, benign sleep neonatal myoclonus, and this one is definitely a seizure. And varieties of the etiology is you have to rule out various causes. And this patient particularly, we was very active, but in between absolutely normal all throughout the seizure, but absolutely otherwise normal at taking the drug. He was on anti-epileptic drug but not responding. This test was done and found to be biotinase deficiency in this patient. So you have to differentiate whether this newborn is having a benign movement disorder or having a seizure, and what is the etiology of the seizure. Another patient, 6-year, female, loss of acquired spoken language, autistic behavior, and everybody will say that this is a classical of Rett syndrome. This is the gait abnormality and the stereotypic hand movement. This is a typical Rett. Another patient of the same, absolutely same presentation. So you will have not to miss any female patient having retarded mentally with small head circumference, doing hand breathing, hand washing, mouthing movement. Do consider this important syndrome is the Rett syndrome. Another patient, we are seeing the ringing, hand washing movement, artistic behavior. Another patient, mutation in MECP2 gene is an important etiology to contributes to 90%, and mutation can also be seen in CDKL5. This is the, again, very important daytime breathing abnormality you can see in Rett syndrome. This is a patient of Rett syndrome, and this is the dysautonomic breathing, which is a signature of Rett syndrome. Another patient, you can see how many abnormalities you can pick up from these 4 videos. Yes, this child is exhibiting chorea. You can see the vacuous smile in this patient. dystonia is there. And the fourth video is having, you can see the hemidystonia prevails in this patient. Now, they see the eye of this patient. Remember importance of examination of eye in not only in neurology, but so many, every discipline of medicine is very important. Lot of message, lot of information is there. And in this patient, you can immediately say and just make the diagnosis and send the patient for confirmation. This is the grade 4 of KF rate. Normally, grade 1 and grade 2 are not visible by naked examination. Slit lat examination is ordered. This is the classical of KF ring. This is the Wilson's disease, and you are seeing this is the face of giant panda. Another patient, you can see the undulating tongue, extrapyramidal feature, KF ring was there, and the most important condition or clinical sign which is seen in Wilson disease is a classical wing beating tremor, as this patient is exhibiting, and these are the patient which are resistant to decoupling therapy. And we know that MRI lesion of the globus pallidus and the head of the caudate nucleus and the substantia nigra can be seen in these patients. Another patient, you have to identify what type of abnormal movement child is exhibiting. Definitely, a patient is having a truncal ataxia and chorea, the child is exhibiting, and upon examination of the eye, there was the presence of telangiectasia over the balloon. And these are the examination. AFP was raised, IG level was normal in this patient. MRI reveals that there is a cerebellar atrophy, and you can see the eyes of this patient. These are the clinical clues which the patient is giving to you that pick up. This is the diagnosis of in this patient. Ataxia, telangiectasia. Another patient. See the ataxia in this patient. While he walks, you can see and upon examination of the eye, you can see the telangiectasia again. And there are some movement disorder which are precipitated by exertion. And this is what is known as the paroxysmal kinesogenic dyskinesia, which is seen in first or second, as in this patient who is exhibiting some movement, and there is a dystonic spasm of the right upper limb. This is the extremely sensitive to the low dose of the phenytoin. This is the PKD. And these are the very common movement disorder and dystonic posturing. These are the small children less than 3 years of age you are seeing. And this is the gratification phenomena. You can see no alternation of the consciousness, cessation with distraction. These are all pelvic thrusting, pelvic rubbing. All these are known, and you have to counsel the family because the parents are really disturbed, socially unacceptable, and you have to counsel, take the family in confidence that this is a treatable condition, and it goes off its own by some particular age. You can see all these patients are exhibiting self-gratification. Video is a very, very important, very, very invaluable. Engage this child in some activity. Reassuring the parents is very, very important. Another condition, you can see lot of these patients. These are some of the, most of the videos are sent by the pediatricians to make the diagnosis. They are really worried. Some are pediatricians. So this is very important. This is the shuddering attacks, shivering attacks, what you can see. All these are exhibiting the same movement. They are conscious, triggering excitement, eating frustration can trigger this movement. Do not occur during sleep. Sort of myoclonus type of activity is seen due to the maturity of the brain. And the diagnosis is always by video recording, and sharing with the seniors is again important. No treatment, and it goes off its own 3 to 7 years of age. Just see this video, what you are picking up. There is a chin movement. You can see the tremors of the chin, persistent tremors of the chin. This is the hereditary chin trembling, and this is the another patient. See the tremors. So, this is obtained from the net, just to show the comparison of these two cases with the available information from the net. This is the rapid trembling, 3 per second is there, and usually mistaken for the seizure. Autosomal dominant inheritance is there because that case number 1 had the father also was having such type of abnormal movement when he was in childhood. EG is normal. So very, very important is the home video recording is very, very important. Just 2 or 3 slides more. Home video recording is a non-inferior to video EEG. See, patient comes in your chamber with lot of description of such type of movement has occurred and the patient was unconscious, a lot of abnormal activity was done. But when see the case, you can immediately dissect it out whether I am seeing a functional one or a real seizure activity or a movement disorder activity. And this is the classical, and this is the way how you can record it. This is a wonderful study. And face recording should be done whole body. This is the recommendation for obtaining video in your routine practice. Whole body recorded, lights should be on, single episode recorded, 2 or more episode recorded, one of the episode recorded, continuation after the episode. So these are, if you get minimum, it should have a 3 sort of points in there. These are the recommendation. Turn the lights on, steady position, interact. Ask the patient in the during the recording, show the pan is there or glass is there, record several events. So these are the tips for obtaining the videos in your routine office practice. This is a very, very, so what Amdekar has said, always try to observe the history, and history is not the only history, but much more. That is very, very important and very, very clear-cut message that you should not afford the history and proper clinical examination. That would mean the observation. What sir says that senseful seeing is observation. Observation helps us to see unexpected things. So senseful seeing is observation. And therefore, all these conditions which we have just described or discussed is picked up just by observation. You need further investigation unless you picked up one. If you have ordered a dystonia, if you have picked up a dystonia, then only you will have to order further investigation. So is the opsoclonus myoclonus. So to acquire the knowledge, one must study, but to acquire wisdom, one must observe. So you have to observe to make you yourself a visionary and having a wisdom. So you can see the observation of video is worth 1,000 words. And you can see that this is the very simple formula that if you have a senseful observation or you have observed all this video, and this is almost equal to the bundle of these books. Thank you so much.
Thank you, sir. Thank you so much, sir. A very, very excellent presentation, as always. I think I must be viewing it almost for more than a dozen times. But at each and every session, you add some more videos to it. So it really sounds me that I am seeing it for the first time. So important take homes: recognizing pattern, observe, observe, and observe. These are the 3 mantras which are very essential. Another thing, what was the onset like? Acute onset, or it was a part of ongoing neurological process? Then what was the pattern like? Hyperkinetic, hypokinetic, because it will decide the treatment modalities. And observe for the comorbid conditions. Very important is the developmental history of the child, and also the examination, not only the neurological examination, but the other system examination like ocular examination, respiratory examination, then looking for organomegaly and so on and so forth. Most of the movement disorders are benign, so hardly they need any treatment, but you have to recognize which of them they need the treatment. And the basic principle, I think, of the treatment is, if these are secondary to some external stimuli like a drug, withdraw that, treat symptomatically the pattern, hyperkinetic, hypokinetic, and treatment of the etiology. I think Diana, if at all you have, or Dr. Omkar, if at all you have questions for Nitin sir, we will take them, and then we will
Okay.
take questions for Anup
Yeah.
sir.
We'll do the
All right.
hematology first.
Sir,
Yeah.
we will do the hematology first and then the
Ah, yes.
neurology.
For Nitin sir only. Nitin sir
I'll
only.
add only one
Nitin
point
sir.
about Anup sir. Sir has
Ah.
reminded me our another session learning by pictorial pediatrics. So this was a classical pictorial pediatrics. Thank you, sir.
So questions
So
to
thank
Nitin sir, we will address first.
Yeah. So thank you, Dr. Joshi. I'll now go to the question answer session. So there are many questions in the chat box, which are related to the dose of iron in different age groups. I think you had shown it in the last slide, second last slide.
Yes,
But can
that's
you
for the
just quickly summarize?
prophylaxis. That's for the prophylaxis. But for
Yeah, just for the
therapy,
prophylaxis. So can you just
therapy
quickly
dose remain the
summarize the
same.
doses?
Yeah, so it's 20 milligram in the first 5 years, then 40 till 5 to 10 years, and after that it become 100 milligram. And you give
All right,
twice a
perfect.
week in the first 5 years, you can make it once a week thereafter.
Okay. So
So
there are
idea
other.
is to give 100 days in a year to small child and 50 days at least in a year to the older children. I think that summarizes.
Correct. Perfect. So again, there are questions on which brand of iron preparation
Right.
you prefer. There are many
So
people asking that.
right. So I use only iron ascorbate because my brain doesn't work at the age of 64 to calculate too many doses of too many syrup with too many strengths. So
So
I
I
know ferrous ascorbate 30 milligram per 5 ml. I can calculate dose. I know drops is 10 milligram per ml. So I know the dose in prophylaxis. And that's what I use. And in older people, older children, we use the tablet, which are 100 milligram. And I generally
okay.
prefer in smaller children to also give associated with folic acid and B12 in good doses because generally nutritional anemias are never only iron; they are mixed. So I mean, if you allow me to take brand names, and I take syrup something like Ferunia Max, which has not only 30 milligram of ferrous ascorbate, elemental iron, but also has good B12 like 500 microgram and also folic acid. So that's the type I prefer in children.
Okay. Yeah, there were questions on brands, so that's fantastic. So there's one more
Sir,
question by Dr. Ashish Shetty. Does
Mhm.
IV iron has any added advantage over oral?
Yes,
And an
surely.
added question, yeah, an added question, will you prefer upfront IV iron in children over
Correct.
oral? Because yeah,
Correct. So IV iron leads to faster rise in hemoglobin. That is proven beyond doubt. So in pregnant ladies, you will prefer to give IV iron if there is a short time to delivery and you don't want to transfuse. In a severely anemic person, you want to raise the hemoglobin without transfusion, then again give IV iron. But IV iron, of course, is the only treatment in some metabolic disorders like IRIDA, etc. Also in patient with sequestration syndrome like malignancy or rheumatological conditions, and in patient with irreversible malabsorption syndromes like short bowel. But beyond that, it is usually indicated only if there is true non-compliance in spite of your best efforts. So you have a mother who just doesn't give iron complete treatment. The child keeps on coming back with 8 gram becoming 6 gram, again 9 gram becoming 6 gram. You know she's not going to listen to you. Just give that option. You come to my OPD when I'm in the morning. I'll give the full IV iron dose and improve the diet at the same time. That works wonder. And because the current IV ions are very safe, that is perfectly done. But don't misuse or overuse because they are expensive.
yes,
sir,
sir.
which one do you prefer?
One
Iron
quick.
carboxymaltose? Sorry, yeah.
Carboxymaltose. Now we use only carboxymaltose even in children because sucrose ion needs to be fractionated, and these people will not keep on coming back every week for such injections.
Joshi sir, yeah.
Sir, very important. The subject of iron and neurodevelopment is very close to my heart.
Correct.
Uh, Sir, as you have already shown the data, I will not go into the detail.
Correct.
My problem is for those resourceful infants and toddlers below the age of 3 years, where
Correct.
you have the maximum growth of brain
Correct.
and iron as a iron contribution from the complementary feeding in most of the Indian communities, not even up to the standard of what is required at that for that particular age group.
Perfect.
So
That
whatever
is the
complementary
reason
feeding the
why.
child is
That is
getting,
the
the
reason why if you
very
see
poor in
the.
iron. Yeah,
Yeah, that's why you see the
yeah,
NFHA data shows that in spite of
yeah,
our progress in last 30
yes,
years, we have not progressed in the incidence of
yes,
iron deficiency
yes.
as a community.
Yes, and another issue, sir, for I am talking for those poor resourceful kids, that the government program also doesn't have a very good iron supplementation formulation for the kids below 2 years of age.
Correct.
The
So now,
whatever tablets are there, they are about 2 years of age. And my point is again is that, sir, even if you give something as a supplement, the parents will always consider it as a drug. At some or other time, they will discontinue it. But the iron needs to be supplemented or given continuously for at least 700 days beyond the postnatal age.
so what's your
For the
proposition?
optimum growth of the brain. For the optimum growth of brain. So, there is any other way IIP can recommend to government that the I'm talking about the fortification of the floor which is being given to the poor in a public distribution system with iron.
Correct. So if you add iron to food, it leads to different taste and color. So people don't like it. It become unpalatable and unpleasant to look at. But you can fortify salt with iron, and there are fortified double fortification of salt with iron and iodine available. Brands are difficult to get, but if you try to get it, it's possible. And that is probably the solution that you can do that. And in the public program now syrups are available, so that's not an issue now.
Again, I think iron with food, the absorption becomes an issue.
Yes.
So again,
If there are
that is an issue.
phytates which are very high in our diet, so I always generally say, that you take vitamin C along with your meals. It helps to increase the absorption of iron, whatever little iron that we are eating in our day-to-day diet. Like Dr. Joshi said, our diets are usually poor in iron. So eating a fruit, citrus fruit, which has vitamin C, like orange or lemon, after your lunch or dinner is a good idea. Whereas to drink tea, which actually leads to poor absorption of whatever little iron is available, is a bad idea. So I think we Indians always eat fruits after our lunch and dinner. That's a good thing. Whereas all English people drink tea after their lunch and dinner, which is a bad thing.
Yeah.
We are
Yeah.
always
So
smarter
there's
than them.
Yeah, that's true. That's so true. So you showed a lot of fantastic studies where there is an association between deficiency of iron and sleep disturbances or strokes,
Yes.
or even there are studies which are having association with mental illnesses, schizophrenia, or even depression, or even autism. So are these more? My first question is: are these predominantly epidemiological studies? That is the first question. And second, you also showed that the hemoglobin may be normal in these
Yes.
patients, but iron levels are actually low.
Correct.
Does it mean that we should start doing iron studies in all these conditions and start therapeutic doses of iron to be prescribed in such patients if in case we encounter, even
So
after hemoglobin being normal?
So generally, who is already anemic with microcytic hypochromic picture with a high RDW and a higher platelet count, and in the age setup where you expect an iron deficiency because of the nutritional cause, there is no need to do further iron studies because you already have evidence. Just treat them. That's what you call iron challenge test. You give them iron, you repeat a CBC and reticate 5 to 7 days. You should reticulocytosis. You do hemoglobin at 1 month. There should be at least rise of 1 gram. You do it at 3 months. There should be near normalization of hemoglobin, and then you continue iron for 2 more months. That's the standard way of practicing iron therapy. But if you want to pick up iron deficient state before anemia develops, then only way you do is the iron store, which is ferritin. Remember, when you do ferritin, your CRP should be normal. So that means the child should not be sick. If you do in a febrile child, your ferritin is going to be normal because of an acute phase reaction. So never do it in a sick child. Do it when the child sickness is over for 2 weeks. So that's the way you know the iron stores. And if you have iron deficiency like picture beyond the growth period, so you have an 8-year-old child with iron deficiency 6 gram, is very unlikely to be nutritional. Think of secondary cause like celiac, like any other, like blood loss, polyps, worms, whatever. So beyond the first 5 years, if you have iron deficiency, which is significant, also rule out secondary causes.
Okay. There are questions in the chat box, sir, which are again asking on iron being prescribed empty stomach. It causes acidity. One
Correct.
second is it is causing a lot of staining of the teeth.
Correct.
Then the compliance becomes an issue. So can you just summarize how
Correct.
we manage these cases?
So first of all, you try always first on empty stomach. If the child tolerates, fine. Doesn't tolerate, you allow them to eat it with the food. If that still doesn't lead to tolerance, then you divide the dose into morning, evening, and generally give iron at night, because then the child goes to sleep then the cramps and everything are less notified by the child than when he's awake. So that's the way you do it. And of course, if still there is a problem, you decrease the dose and then gradually increase. You make it alternate day or twice a week and then gradually increase. I'm sure 99 or 999 or 1000 times you will be successful in completing the treatment. For that 1% or 1% or 0.1%, you always have the scope of giving them total dose IV iron if they are completely uncompliant with your, in spite of all your best efforts. Coming to staining of teeth, the iron stains the teeth, not and the tongue. But the problem is the tongue, the coating goes away after a few days, but the teeth may remain stained till the time the child is taking iron. And parents don't like that the teeth look black. So what we tell them that you take a long spoon and put it on the back of the tongue, and then the child swallows. Then the iron doesn't touch the teeth. And if the child is a little
And that,
older
yeah.
and can take tablet and crush the tablet and give, or just make the tablet into half and give. There are ways and means. And always tell them it's better to protect your brain than your teeth. In any case, teeth staining is temporary, not permanent.
Yeah. So even the taste doesn't become an issue once you do this.
Yes,
So there
absolutely.
is one more question: how to monitor the response of iron therapy in a known case of thalassemia trait?
So there's no iron therapy in thalassemia trait, because generally when you say trait means they are actually going to have iron overload over the long many years, because there is some increased absorption. But having said that, lot of people who are thalassemia trait in our country have concomitant iron deficiency, to the extent that sometimes your HbA2 may not even rise to the level that you want. So sometimes you give them oral iron and repeat your electrophoresis, and you'll be surprised that what was borderline HbA2 now becomes as definite 4, 4.2, 4.5, like that. So you treat them with oral iron if there is concomitant iron deficiency. Like suppose you have a thalassemia trait with hemoglobin of 5.5. You don't expect that to happen in trait. There is concomitant iron deficiency. You prove by doing ferritin. It is 2, 3, 4 nanogram. Give them short iron for 2 to 3 months and stop. And after that, you don't continue to give them iron. So you write, patient is known case of thalassemia trait, do not give oral iron again and again.
Yeah. So you did show one of the slides. You did show that exacerbation of infections actually doesn't happen, but still we can
Correct.
always try giving iron at a time of discharge.
So in
So now there's
ICU
one.
setup, no, in an ICU setup or a sepsis setup, you should not give iron. But
Yeah.
beyond that, for routine diarrhea, routine viral infection, routine scarlet fever that you're seeing now, if you have iron deficiency, at the time of discharge, you definitely put them on oral iron.
All right. So there's one question which is saying that there are multiple studies saying that iron treatment has been associated with acute exacerbation of infection, in particular malaria.
No, so
And
that's
on the
why I
other
said.
hand, iron deficiency is associated with reversible abnormalities in the immune function. So can you some throw light on that?
Exactly. So I showed you the meta-analysis which is done by Dr. Gera's group from Delhi, and they have looked at not one but several studies about iron and infection, and they have found that except for diarrhea, which may little increase, there is no association with any other disease significantly. So while you may say that okay, some side effect happen because oral iron, but they are not significant when you do it as a proper study. So the end point is that no matter what you use, like say for diarrhea, the random effect model showed 1.1%. So that was the only one which was significant. Rest all were below 1, like non-diarrhea 0.9, malaria was 1.07, but confidence intervals were below 1 and above 1, so it was not significant. So bottom line is that if you give iron to a malaria child at the time of discharge is the best way, because the iron is trapped in the reticular endothelial system when there is malaria.
I think we are nothing short of time. So I
नहीं,
think we have
ये-
covered most questions from the chat box.
Yes.
And also the other questions.
I have one question.
Yeah.
Yes, Ram.
Yeah.
Don't ask
Sir-
this is my exam ले रहा है.
नहीं, sir. Very simple question.
Hello, sir.
Last
sir.
question, Ram. Last question,
हाँ.
then we move to Anup.
One question is, what is the role of iron in pica, and do we do the iron study in pica before starting the
Correct.
iron?
So if you have a neurologically challenged child with pica, then that is a sign of his neurobehavioral issues. But if you have a normal child coming to your clinic and is running about, hyper irritable, and also has pica, be assured it is iron deficient. I mean, there are ways you can prove if they can afford of course, you should do a CBC at least and do a ferritin if possible. But otherwise, just put them on oral line and see over next 2-3 months.
Okay.
Sir, the
So,
last
sir, as
question.
always, you were fantastic. So
Sir,
I'll give it
last-
over to.
नहीं,
Sir,
नहीं,
last
एक
question.
Sanjeev,
Last question. Last question.
Sanjeev sir
Fine.
wants
Yeah.
to ask.
Yeah, sir.
Yeah.
Sir, last question.
Sir.
As in addition to Omkar's comment about the correlation of iron deficiency and falciparum incidence of falciparum malaria, there was a huge study from South Africa that by one of the group that iron deficiency was protecting against the falciparum infestation.
Correct.
And there was this so-called, your last slide showed hepcidin. The concept of hepcidin was there for that particular study. Will you please throw a light on
No,
this?
so whenever you have less hemoglobin and RBC is less likely to get parasitized by the falciparum malaria, but not Vivex.
Okay.
And that's the reason why you see why you have G6PD, thalassemia trait more common in the malaria belt is because it protects against severe falciparum malaria and mortality. But that is just an ecological correlation that we have shown. So in a sick child with falciparum malaria, of course, you don't give oral iron till the time they are discharged. But because there will be incidence of falciparum malaria, etc., you will not give iron to many children who end up. I think that doesn't appeal to me. So in a non-sick child, whatever his disease may be, just give them iron.
Okay. So thank you, sir. You were always, it is always a treat to listen to you and also to watch and listen to Anuparma sir. Unfortunately, Anuparma sir has to leave because he had some family function to attend. So he has extended his apology. So he won't be able to answer the queries. But on behalf of Maharashtra IP, I thank Dr. Ram Gopal for giving this opportunity, Dr. Amol for extending all the support, and the most important, Dr. Nitin Shah sir, Dr. Onkar, and Dr. Anup Parma sir for accepting our invites and enlightening our virtual audience with very important topics of day-to-day practice. Thank you, all the virtual attendees. They are almost touched 300. So again, a super hit program, Ram Gopal. Congratulations.
Thank you, sir. It's all your efforts.
Thank you.
And thanks, Dinah.
Thank you so much, Ram sir.
For being
and
the
Shah sir, it was actually a pleasure listening to you
Dinah.
on topics which are other than hematology. So fantastic. Lovely. Seriously. Thoroughly enjoyed it.
Thank you.
And thank you so much, Ram sir, for the opportunity.
Thank you, sir.
Good night, everyone.